I'm Sarah Langer. I am a retired neurologist and was ultimately diagnosed with dementia with Lewy bodies.
My name is Arnie Barish. I'm a former podiatric foot and ankle surgeon. I was diagnosed with mild cognitive impairment with early onset dementia.
I'm Alan Schooley. I'm a pediatrician. I now have Alzheimer's.
I'm Gary Schmidt. I'm a retired family practice physician. I now have dementia with Lewy bodies.
Tom Mahoney. I'm a primary care internist and also have done a lot of public health work, diagnosed with early stage Alzheimer's.
I'm David Compton, and I'm a retired family physician. I have Alzheimer's disease.
The physicians in this group had as much or more of a problem getting a diagnosis than everybody else. And it's like, holy shit.
Interesting. Everybody has these stories of their early diagnoses being so traumatic. And it's just confusing. And you're talking about a cognitive disorder, and it's confusing family, confusing for the individual, and unfortunately confusing for the healthcare professionals in the industrial medical complex. That's tough.
The response was what I would frequently have told patients. Yeah, something might be going on, but it's not enough for us to catch.
I gave them a list of my symptoms, looking for just confirmation that yes, these symptoms could be from Lewy bodies. And basically what I said was, you don't have Parkinson's, and I'm not sure what to do with all these symptoms.
And it was tough workup. I had all these well-meaning physicians here. You've got attention deficit, take this medicine, or you're depressed, take this medicine. Oh, you need to sleep more, take this. All those medicines make me worse. Everybody's wanting to give it time. It's instead of saying, let's do some more testing. And finally, I got into who I see now.
All too often, doctors will, and this applies to neuropsychologists and all kinds of medical professionals, but they say, well, this person is not 2.5 standard deviations from the mean in their language function. They're not 2.5 standard deviations below the mean in their visual spatial function. They're not 2.5 standard deviations below the mean in terms of their memory function. Therefore, it's no big deal. But the fact is, in reality, real life translates into the summation of these deficits. And their families know that this is a change. But unless you've got somebody strongly advocating for you, you're sunk.
When I was diagnosed, the resource that I was given when I left his office was, I know 2 psychologists on your side of the water that will help you deal with the depression that you're going to have. That was the resource that I was given. Somebody
came in and they talked to me and they said, you should do this and this and this and this, and then you do your what you can, and then just die. And he was like, do you want to die earlier or later? And oh, you shouldn't really do anything that's not, you don't like, and things like so sort of. That's about the best.
Actually, I part of my career, about 20 years, included being a physician on a dementia unit, which is obviously people with very severe, more end-stage disease. But what I never had at the time was a recognition of what can be done in early stage and progression. And I think that healthcare providers, including myself at that time, never had a sense of things that could be done or care that could be given along the journey. The medical mindset is at the end stage. Without consideration for those of us who still have something to do and to offer.
I have a cognitive loss. I have very early stages of Alzheimer's disease. But if I tell somebody I have Alzheimer's, they automatically put me in the in their head have put me in the nursing home, staring out the window, or it depends, So I'm going, no, it's not like that.
When books or movies have been done about people with dementia or Alzheimer's, it's almost always looking at the terminal end of it. So that's the outlook that the public has towards it, that this is just a awful terminal disease.
So, it's always there. It's always been there, and always will be. And the question is, how we can change things to make it where people can survive.
People are afraid to diagnose it early. People are afraid to address their symptoms because they're afraid to get that dementia diagnosis. And that's a mistake, because this is a disease that can be modified. And it's like when you think of somebody with diabetes, oh, that's unfortunate. Like, you use insulin, use pill. That's a disease. You get cancer. Oh, that's really bad. But now in the 50s and 60s, they viewed cancer as that. Just don't look for it. Can't die. You can't do anything about it. Goodbye. Till now, yeah, it's treatable. We should take the same approach with these diseases.
If you have a heart attack, they automatically send you to all the right people. And they have you see a dietitian. They start having you do exercise, and they have all these things plotted out. And they give you the medications. If you have a diagnosis of a dementia or a cognitive impairment, I like to use the word cognitive impairment because dementia has this stigma about it. So if you have a cognitive impairment, there really isn't, but there's things that you can do.
So my recommendation is that upon presentation of a patient to clinic with cognitive complaints, a social worker or psychologist, an occupational therapist, a physical therapist, and a speech pathologist all be recruited to assess the patient for cognitive impairment and any other potential psychiatric or physical complaints that might accompany a neurodegenerative disorder. And I think it greatly enhances the diagnosis.
Pay attention to the early symptoms. If somebody comes and say, I'm really struggling with thinking through this, and pay attention to that. Don't just say, oh, it's this, here's a pill. I mean, in medicine, we've gotten to the point of where with classics, they train, well, here's a disease, here's treatment, then pharmacology. But with changes in the last 3 or 4 decades, it's disease, pills, then treatment. We've got it all wrong.
When I was first diagnosed, I looked at organizations that I could turn to, and the most frequent offerings were for the caregivers. The focus was on how do you deal with someone who can't function themselves. And I was really looking for something that told me how to function best by myself.
And that's what I think, what we're trying to do, with this group is figuring out simple things that can help people who have these diseases.
So we set up our support groups, but just people with it, peer driven. No anybody else in the room, just people with it, talk about it. Oh, they have a lot to say.
Because they're people that have had life experiences like you have, living the same disease, and you can talk the same language and understand and see how they are functioning well in their environment. What we want to do as a group is somehow reduce the stigma of dementia and educate doctors, nurses, the general population, and what the disease is and how to respond to people when they have the disease, and let them know that we're still people. You don't have to be afraid of us.
What has drawn me to this is to how to live with Alzheimer's, not how to end with Alzheimer's.
Yes,